Okay, so are you guys ready?
Yes, let's do it.
Okay, today we have a 65-year-old female who consults due to 3 days of abdominal pain and lack of bowel movements. Do you want me to stop there, or do you want me to give you a little bit more of the history?
I think you can give us a little bit more history.
Sure. So the patient reports that 2 weeks ago, she had an episode of dyspnea for which she went to the doctor and he performed a decompressive paracentesis. It made her feel better and she had been good until 2 days ago. She started experiencing diffuse abdominal pain and nausea. Um, she also reports that she hasn't had bowel movements in the past 3 days. And she also noticed that she had a fever due to chills, but she didn't take the temperature with a thermometer.
All right. Well, we have some interesting information already, which is that we know that for some reason this individual required a paracentesis. So we have some potential clues for us to figure that out here, in addition to the primary syndrome, which seems to be abdominal pain and also lack of bowel movements. I think if we think about right, why might this person have or need a paracentesis, and how might that give us some clues into their abdominal pain, right? Paracentesis is required for the management of ascites sometimes, and ascites can be related to portal hypertensive causes and non-portal hypertensive causes. The base rate of disease would say that the vast majority of cases are from portal hypertensive causes, whether that's most commonly cirrhosis or sometimes non-cirrhotic portal hypertension, which in the Western world is usually related to heart failure, but globally the most common cause is going to be schistosomiasis. And so if we take those findings and say, well, gosh, how could that be related to the primary finding of abdominal pain and a lack of bowel movement? The first thing that comes to mind is potential complications of ascites. And particularly in individuals who have underlying cirrhosis and portal hypertension, they can develop spontaneous bacterial peritonitis. So that's one way for us to say, okay, we know that there was a paracentesis. How might that be modulating their abdominal pain? Thinking about the complications of ascites, the most morbid of them being the development of spontaneous bacterial peritonitis. And then sometimes, if there's a disruption in the integrity of the bowel lumen, we also think about secondary bacterial peritonitis. But before we even really dive too deeply into the ascites complications, right? Abdominal pain is a very broad syndrome. It sort of deserves its own spotlight. So I will pause there on the ascites discussion and kick it over to Sharmin for whatever else you want to talk about related to what we have so far.
Oh, that's beautiful, Jack. Yeah. So there's so much richness to talk about. And I think we've talked about like abdominal pain. And when we think about misdiagnosis of abdominal pain, I already saw VIPO being mentioned. So thinking about like your vascular etiologies, your itises, your inflammation, perforation, obstruction, and a woman of childbearing ages, thinking about ectopic pregnancy. And I think that's a really, really good framework to have. One thing that I thought it would be cool to think about was the lack of bowel movement. And if we say this is truly constipation, oftentimes we see constipation is so common. We often think like, idiopathic IBS is the etiology that is like most common. However, there's like when they're in the younger patients, and also when it's acute on onset, followed by like with more like systemic symptoms, that's when you want to really worry about it. And the way I kind of think about it, my two big buckets that I don't want to miss is like obstruction, and the other one is like decrease in motility. So whether the obstruction is internal from like a structure, like a cancer, adhesions that is causing large or small bowel obstructions, or whether it's like external, like something we often see is like urinary retention, and sometimes like ascites or pelvic masses can play into that as well. And the other one I like to think about is like gut is a muscle, so whatever that causes decrease in motility, that can lead to constipation as well. So that's like your electrolyte abnormality. I saw hypercalcemia being mentioned. Hypokalemia is another one to think about. Meds, right? Opioids, your anticholinergic ones, decrease in a decrease in like autonomic dysfunction is another one to often think about. Like we most often see it with Parkinsonism, but there's like a whole slew of autonomic or like muscular issues that can cause it as well. So that's usually the list I like to go down with. But I think in a patient who is coming in with a procedure that was done, thinking about complications of a procedure, perforation being one of them, and then thinking about like how the SIDs play into it. And lastly, just, remembering our no misdiagnosis and making sure we evaluate for those first.
Fantastic, Sharmin. That was absolutely fire. I love that. Amanda, why don't you take us forward? Oh, we lost her.
I'm back. I'm sorry.
Nice. Welcome back. It's all good. My internet glitches all the time here.
I'm sorry, guys. I just missed the last part. So I don't know if you want me to tell you a little bit more about the patient or you're still discussing some stuff from the case.
No, go ahead. Go ahead and take us forward.
Okay, great. So with the past medical history, she does have cirrhosis. It was diagnosed 4 years ago. She also has hypertension. And one thing notable was that she had an SBP 6 months ago. The meds that she's taking, she's on furosemide, propranolol, spironolactone, and enalapril. And then with the allergy and the surgery history, it was unremarkable for both of them. She says that she does not consume drugs, does not smoke, or consume alcohol. Do you guys want me to jump to the physical exam? Yeah? Okay. So with her blood pressure, it was 92/65. Pulse, it was 79. Respirations, 18. She was saturating 89% from air. And her temperature was 38.4 Celsius. The patient appeared tired. Her oral mucosa was dry. Her pupils were equal, round, and reactive to light. In cardiovascular, she had a regular rhythm and no murmurs heard. Pulmonary was unremarkable as well. Abdominal, she had an increased abdomen diameter with a positive fluid thrill and diffuse tenderness. And in the lower extremities, she also had some edema below the knee. And neurological, it was unremarkable. She was alert and oriented in person, time, and place.
All right. Thank you so much, Amanda. So, as Jack beautifully deduced that this patient has underlying cirrhosis, it sounds like a decompensated cirrhosis with ascites and prior history of SBP. And kind of looking at her medications, just taking note that, propranolol, she's on for potential. So the other thing that comes to mind for various C prophylaxis. And I'm not sure if he's on, she is on antibiotic prophylaxis for SBP, given her prior history of SBP as well. So I'm going to just jump into maybe the vital signs here and then leave the rest for Jack to discuss. So what the vital signs is quite significant, and I'm worried about this patient. So she is febrile with a history of underlying cirrhosis. A heart rate of 79. Again, she has a beta blocker on board, so she might not be mounting as much tachycardia. And her blood pressure in the 80s over 60s. She has a history of hypertension and on ACE inhibitors to begin with. So this blood pressure most likely is low for her. So she is hypertensive, she is febrile, and she is hypoxemic. The question with the hypoxemia is that, is this like a primary lung cardiovascular or a potential way to link her distension and like abdominal pain is that if she has increased distension and you're kind of like the abdominal is pushing and causing more atelectasis and causing some degree of hypoxemia that way. But again, like something to think about how we can link it and also work it up separately as well. Jack, what do you make of the rest of the exam?
Yeah, I think one of the things that is the most striking, I guess the two things that are jumping out beyond the vital signs, is the fact that we're seeing increased diameter of the abdomen again, only 2 days after she had what sounds like a therapeutic paracentesis, right? So there can be two different types of paracenteses. There can be diagnostic paracenteses, usually a small volume of fluid, and then a therapeutic paracentesis, which is oftentimes up to liters of fluid that are taken off. In this case, we know that it was a decompressive paracentesis. In other words, she was having symptoms of shortness of breath, probably from limited diaphragmatic excursion. And usually in those scenarios, there's a large volume of fluid that gets taken off. So the fact that fluid has reaccumulated after what I'm inferring, which may be an incorrect inference, was that a large volume of fluid has been taken off, I think is worth noting, right? Because certainly those complications of ascites that we mentioned before are absolutely at play. And I do worry about potentially a complication of the prior paracentesis being more and more prominent here because of what seems like a relatively rapid reaccumulation of ascites in the setting of the recent paracentesis. The other thing is that she's quite tender to palpation. And I think that is worth noting for two reasons. One is that individuals who have SBP or spontaneous bacterial peritonitis tend to have more subtle exam findings than those who have secondary bacterial peritonitis. The reason for that relates to what happens when there is acidic fluid in the abdomen, and that acidic fluid basically separates the visceral surfaces of the peritoneum from the parietal surfaces of the peritoneum. And it's the parietal peritoneum that usually gets inflamed when we have an acute abdominal process happening, right? So the visceral peritoneum gets inflamed when we have appendix or when we have appendicitis, and then that usually progresses to involving the parietal peritoneum. That vague, crampy abdominal pain that starts appendicitis is from the visceral peritoneum being inflamed, and then it becomes more focal when the parietal peritoneum is inflamed. Ascites separates those two, so it can make it harder for the parietal peritoneum to get inflamed. So usually the degree of abdominal pain is more subtle on exam. So I think in the setting of somebody who has ascites and has very focal tenderness to palpation, makes me worried about the fact that, or makes me wonder if there's a much more inflammatory process happening beneath the surface than what we may be led on by the physical exam, because ascites tends to blunt physical exam findings. So if we start to put this picture together of prominent abdominal tenderness after a recent paracentesis, I think the case to be made for secondary bacterial peritonitis is getting stronger and stronger. It's important to note that it is by no means the most common pathology here, right? The base rate would favor other causes of abdominal pain that Sharmin mentioned up front, as well as spontaneous bacterial peritonitis. But the probability of secondary, I think, is mounting beyond the traditional base rate based off of a more aggressive inflammatory syndrome, as well as a more aggressive focal pain syndrome here as well. And we can then start to prepare ourselves to try to interpret the acidic fluid analysis if we get there. And so it's a time for us to start to say, well, gosh, what would we expect if we saw SBP or spontaneous bacterial peritonitis? And what would we expect to see if we saw secondary bacterial peritonitis, right? In parallel to exploring that hypothesis, we still need to do
Oh no. Oh, Jack.
Am I back?
Yeah, you're back. You're back. Or maybe not. Oh, it was so beautiful too. uh, maybe we'll give it another second.
Can
Okay.
you hear me?
Yeah, we can hear you now.
Okay. I was just saying work up or we're going to work up abdominal pain, other causes in addition parallel. But I will turn it back over to you, Jimena, to take us forward.
Thank you. I'm so glad that you're back. I was worried that your train of thought was interrupted. So with the exams, we have a white blood cell count of 5.76, with predominance of neutrophils, 80.2%, lymphocytes, 15.8%. Her hemoglobin was at 12.5, hematocrit 36.1, and platelets 165K. With the comprehensive metabolic panel, her creatinine was in 0.65 with a BUN of 15.5. Her glucose was 100, and the sodium was 135, and the potassium 3.41. Her calcium was at 7.83. Then we also got some liver tests. Her bilirubin was at 2.31, with the direct bilirubin in 1.58. ALT was 17, AST 49, GGT 48, and alkaline phosphatase 125. Her albumin was 2.71. And we also got some quag tests. The PT was 18 seconds, PTT 39.6, and her ENR was 164.
All right. Well, I think I was hoping that the labs would do more for us here, but I can't say that they're moving the needle a lot for me from a probabilistic perspective. And I think that reflects how tough the problem of abdominal pain is to solve without imaging, and how tough possible complications of ascites is to solve without a paracentesis. And so as we wait for that data, I think the question is, can do any of these lab findings falsify some of the hypotheses that we were considering? Sharmin, I'm curious to hear your thoughts on this. I will say for me, like sinister intra-abdominal pathology with a normal white count, while maybe not the most common thing that we see, certainly feels plausible, especially in someone who has some qualitative immunocompromise from underlying cirrhosis. And so I think, I'm not sure that if I'm just being as authentic as possible to the case, I'm like, these labs exist, but I don't know that they're really shifting the probabilities a ton for me here. But yeah, I'm curious. What are your thoughts?
Yeah, I totally agree. I think this is a patient who has underlying cirrhosis coming in febrile, hypoxemic, slightly hypotensive with a concerning abdominal exam on imaging. I think it's also interesting that, she doesn't have any sign of hepatic encephalopathy, but sounds like she has evidence of like volume overload on exam. So yeah, I totally agree with you. I think this is someone that I still would want to get some imaging on. I would, again, like I'm thinking about both the hypoxemia and the abdominal pain. So, as you mentioned, like paracentesis to get a little bit more detail. And I think one thing to pay attention to is like color of the ascites as well. I love that you point out the secondary peritonitis as well in someone who's had a procedure in the past. So I continue to be quite worried about this patient and would get those as soon as possible. Oh, the other thing that I was just paying a close eye on was the hemoglobin. Just because, when you had a prior history of paracentesis, thinking about blood as well, that if you nicked a small vessel or something, but it sounds like the hemoglobin's stable, but that's something else that I was like keeping a close eye on.
Thank you guys for that discussion. To give you a little bit more of information, the patient had a hepatitis panel of hepatitis A, B, and C, and all of them were negative. Her ESR was 80 and the CRP 7.7. We also got her an abdominal ultrasound that confirmed the presence of hepatomegaly and gross ascites. The liver showed markedly increased echogenicity on liver parenchyma. This patient was in Guatemala, and she didn't remember what had been told exactly to her 4 years ago that the cirrhosis was diagnosed. But the signs were suggestive of non-alcoholic fatty liver disease. And this is like the last information I'm going to give you, and then I'm going to reveal the test that's going to go to the diagnosis.
All right. So, with the elevated ESR and CRP, there's like marked inflammation. And again, thinking about the patient that was febrile inflammation, I think, number one, number two is thinking about anti-infectious etiologies. And I would just prophylactically start, after I do the para, I think, put her at least on SPP. So we just have tracks on here. The question, again, as mentioned, is that are you worried more about secondary peritonitis here, and thinking about like what causes of secondary peritonitis? We often think about staph or strep. So whether you would add a vancomycin here as well. The other, I really appreciate you, Hemana, thinking about like etiology of her cirrhosis. She has hepatomegaly. I'm often thinking about more like nodularities as seen. I'm curious if the abdominal ultrasound had any Dopplers, so thinking about vascular pathologies as well. So I think for me the next test would be a paracentesis. I don't know, Jack, do you have any additional thoughts?
No, I'm with you. I think for the acute syndrome of the abdominal pain, fevers, tachycardia, or sorry, the abdominal pain, fevers, and tenderness on exam, sort of exploring that with a paracentesis. And I think then also kind of as we pursue all that, I think I appreciate you bringing up the possibility of an alternative etiology of her liver disease and her liver findings. I think Jimena giving us some of those lab findings maybe brings up the possibility that diagnosis is in question. And I think it's important to highlight that we oftentimes make the inference that someone has cirrhosis from certain imaging findings, but those are by no means perfect inferences to make. In other words, many individuals who don't have cirrhosis will have a lumpy, bumpy liver on ultrasound or CT scan. And many individuals who have liver disease from other causes can have a lumpy, bumpy liver on ultrasound. And so I think as we kind of explore the acute abdominal pain and possible infected fluid hypothesis, thinking about, gosh, well, how definitively do we, or how comfortable do we feel clinching that she had liver disease here? Because as you mentioned a couple times, in the background, we have to sort of explain where this hypoxia is coming from. And if we think about some of her past medical history findings, she had SBP 6 months ago. And it's incredibly rare for someone to have SBP who doesn't have underlying cirrhosis. But people can develop cirrhosis from a number of different etiologies. And so if we say, well, how can we potentially link cirrhosis and hypoxia together? There's a couple ways that can happen. One is the development of portal pulmonary hypertension as a late stage complication of end stage liver disease and severe cirrhosis. I won't go into the pathophysiology of portal pulmonary hypertension. It involves west zones of the lung and all these things, but effectively you get abnormal vasodilation at the bases of the lungs and shunting to those areas, or I should say preferential blood flow to the lower areas of the lungs that are less oxygenated than the higher areas of the lungs. So those individuals can develop hypoxemia from portal pulmonary hypertension. There's also some things that can lead to hypoxia and lead to the development of cirrhosis, and that would be things like pulmonary hypertension and primary right heart failure, where individuals can develop chronic congestive hepatopathy. And then from the chronic congestive hepatopathy, it may progress to things like ascites from the pulmonary hypertension and congestion, as well as some degree of cirrhosis, probably from chronic hepatic congestion. And as you said, Sharmin, she has some syndrome of volume overload, which is totally possible from cirrhosis, but may also be from underlying cardiac disease as well. I mention that because someone who has this degree of pulmonary or portal hypertension from cirrhosis, you might expect to have lower platelets because of than what we're seeing here. And so sometimes individuals with cardiac ascites may not have the same degree of portal hypertension. Individuals with primary cirrhosis might as well. And so I think those would sort of be the two paths to explore: figure out her ascites, and then also see if maybe there is a alternative cause of her lumpy bumpy liver and hepatic dysfunction. And I think one place that could link the hypoxia and the liver together could be the right heart and the pulmonary vasculature. But yeah, I mean, otherwise beyond that, I think that's a little bit of reaching for straws there. So take us home in terms of where this case ended up.
So definitely we also got a paracentesis, and the studies from it revealed abundant neutrophils over 350 and abundant fibrin. So the patient was diagnosed with an SVP. You guys were spot on the diagnosis. The cultures that came back later revealed Staph aureus. So definitely we think that the decompressive paracentesis 2 weeks ago was definitely the cause of this. As you also said, this patient had an SVP 6 months ago, and this is a patient who was not very well controlled in terms of her medication for the hypertension and for the cirrhosis. So we think that that's probably why she just kept having multiple SVPs. And I love how you guys mentioned the etiology, because this case was a little bit reversed in the sense that because of the history that we had, we got the paracentesis a lot quicker than I gave it to you guys. But definitely just finding the etiology of the cirrhosis was one of the goals. And it was important to also check all the things that you guys mentioned about the portal hypertension. Just to give you guys a little bit of an answer of why the hypoxemia she got in a chest x-ray that show images suggestive of atelectasis. So that's what we attributed the dyspnea that she was presenting with.
Wow, this is such a great case, Jimena. Thank you so much for presenting. We often take care of patients with decompensated cirrhosis, and I've actually personally never seen and a secondary like peritonitis after a paracentesis, which it can definitely happen. So thank you for bringing this to our attention, and also like thinking about. I love your thought train of like, oh, how can we further optimize this patient down the road? I think, thinking about a Lasix spironolactone, if her potassium allows for it, would be a good, we usually think about 5-to-1 ratio for that. And trying to remove as much paracentesis. Some of these patients also require more frequent paracentesis already scheduled as an outpatient. But I really, really loved this case. Thank you so much for presenting, Jack. What are your any additional thoughts?
My only thought is just how Boston
Oh, sorry, Jack. We can't hear you quite well. Oh, I'm always sad when we don't
am I
get
back?
Jack. Oh, I'm sad. Sorry, Jack. I think the connection is quite poor. But thank you so much.
I'll type it.
Yeah, sounds great.
Jack, we love to see your mustache on VMRs, but maybe if you turn off the video, it's going to improve the sound. So you don't have to type that much.
Is that better? Can you hear me or still no?
Yeah, coming up.
All right.
So good.
Fire advice. My only reflection was just how boss it was of Sharmin to predict the Staph aureus and the culture. And then I just wanted to express my gratitude for you bringing this fantastic case to us today. A lot of learning, a lot of great practice. And we got to explore a lot around the problem space.
Sorry, Jack, we can't hear you again. Oh, such a bummer. But I'm glad we got I'm glad we got most of your pearls in this session. Thank you so much, Amanda, for presenting. For everybody in the chat, thank you so much for uh, your awesome thoughts. It's so, I always like love trying to read as much as possible. Sorry if we missed some, but thank you. Mariana, we're ready for your teaching points.
Okay, let's go. Thank you, Jimena, for this interesting case, and thank you, Sharmin Jack, for this amazing discussion as always. So let's go to our teaching points. So we started with a patient with abdominal pain, but right in the beginning we had a clue because the patient required paracentesis. And then we started to think why this patient had to undergo this procedure. And then we started to think in ascites. And then we discussed portal hypertension causes or non-portal hypertension causes of ascites. And for portal hypertension causes, we had cirrhosis, heart failure, and schistosomiasis. And in a patient with portal hypertension and abdominal pain, we have to think in secondary bacterial peritonitis. And then we try to let our diagnosis a little more broad, and then we discussed obstruction, decrease in motility, electrolyte abnormality, MED, autonomic dysfunction, complications of the procedure, such as perforation. And then with the physical exam, we found out that the patient was febrile. She had mild hypotension and hypoxemia. And then we started to think about hetalectasis. And then Jack mentioned something really important here, that was the patient had increased the diameter of the abdomen 2 days after therapeutic paracentesis. And then we started to think in complications of the procedure, mainly because of the rapid reaccumulation. And then we discussed that the patient can have peritonitis, and because of the ascites could have few signs in the physical exam, so we have to be aware of that. And in the diagnostic paracentesis, the color of the liquid could be really helpful. And then Sharmin said that the patient had signs of infection, so we should start on antibiotics and with ceftriaxone and vancomycin to cover staph. And vascular causes of liver failure should be assessed. And then we started to think where the hypoxia is coming from. And then Jack taught us about cirrhosis and hypoxemia like together, and we started to think in portal pulmonary hypertension as a late complication of cirrhosis, and also pulmonary hypertension in primary heart failure. But the final diagnosis ended up being something that we discussed all the time, that was secondary bacterial peritonitis. Thank you all for listening, and that's what I have for today.
Boom. Wow. I'm just always amazed about how fast you all can do these teaching points so well. So thank you so much, everyone. We really appreciate you, and we'll see you soon. Thanks, everyone. Bye.
Should we, oh, there it is. Should we wait for the whiteboard?
There it is. You made it happen. Thanks, Ashutosh.